So next we have Dr. Ravi Kumar Bhukia, who will be, is he here, Dr. Ravi? Yeah, so he'll be speaking on the evaluation of bleb morphology among operated juvenile open angle glaucoma patients.
Good morning, one and all. Myself, Dr. Ravi Kumar, as a presenting author. Co-authors are Professor Ramajit Shiota and Professor Vinay Gupta. I am presenting evaluating bleb morphology among operated juvenile open angle glaucoma patient. So, as you know, juvenile open angle glaucoma affects mainly age group of 10 to 40 years and high IOP, that is more than 30 millimeter of mercury, and deep steep cupping with diffuse visual field defects, open angles on gonioscopy, and JOAG may differ from the other POAG. The former of more severe disease in the JOAG. So the long-term changes in the bleb morphology in the same patient at 1 month, that is good diffuse bleb, at 1 year, avascular, and 1.5 year, that is also avascular bleb, at 3 years, avascular and cystic bleb is there. So duration of the bleb increases as the changes is seen in the same patient of the trabeculectomy bleb. So in the same patient, either eye, one eye has cystic bleb, other eye has good diffuse bleb. So this difference we are seeing in same patient in operated JOAG patients. That's why this study has been done. The rationale of this study is juvenile open angle glaucoma patients undergoing trabeculectomy for IOP control need to live with bleb for a rest of their life, while avascular bleb is threat and fibrosed bleb is unwanted. In order to achieve the good ideal diffuse bleb, one needs to understand the factors leading to the achievement of the such bleb, such that these blebs may alter the preoperatively or intraoperatively or postoperatively. The objectives of the study is to evaluate the bleb morphology among operated juvenile open angle glaucoma patients to determine the factors affecting the bleb morphology in operated JOAG patients. The secondary outcome is IOP measurement. The inclusion criteria is primary open angle glaucoma with age of onset between 10 to 40 years, IOP more than 22, in one or both eyes on more than 2 occasions, open angles on gonioscopy, and glaucomatous optic neuropathy in one or both eyes with visual field defects, loss consistent with optic nerve damage. The exclusion criteria are history of steroid use, secondary glaucoma, patient not willing for give consent, patient in whom bleb photographs could not be taken. The methodology of the study is the sample size is 100 eyes of 100 patients in each patient at least 1 year ago operated. Then 20 eyes of 20 patients were evaluated prospectively over 1 year of the patient. Bleb photographs were taken and graded. The methodology is bleb photographs of JOAG patients were evaluated by masked observer and graded using the simple classification and same magnification by us as classified avascular blebs, fibrosed bleb, and good diffuse blebs. Bleb photographs were evaluated and correlated with following factors. The following factors are pre-surgical or pre-op factors: age at the time of surgery, gender, baseline IOP, duration of anti-glaucoma medication, and the size of the surgical factors like Tenon's thickness, use of mitomycin C 0.02%, size of scleral flap, size of ostium, and size of iridectomy. Post-op requirement of medications. These pictures showing the avascular bleb, and coming to the fibrosed bleb, this is the fibrosed bleb and this is the good diffuse blebs. The surgical technique is fornix based superior nasal localized peritomy was done, and one group is around 0.02% MMC subconjunctivally for 3 minutes and wash with saline, and other group is no MMC usage. The results, coming to the results, total number of patients are 142 patients and 122 patients in retrospective study and 20 patients in prospective study. Coming to the number of eyes, total number of eyes are 180, and retrospective study, total number of eyes are 160 and 20 eyes in prospective study. The bleb photographs available from retrospective study is 109 eyes, and bleb photographs available for all 20 prospective eyes. So the demographic data for all 142 patients at the age at the time of surgery is around 27 years and more commonly seen in male patients, and baseline IOP is around 37, and duration of all medical treatments in months are around 53 months. So age at the time of surgeries, so it is usually most commonly seen around the age of 21 to 30 years of age group. Then coming to the bleb morphology. 109 eyes had their bleb photographed at 1 year among the retrospective arm of the study, and 20 eyes of prospective arm of the study using the same conditions and magnification. Blebs were classified by 2 independent masked observers. In cases that there is disparity in the classification, the cases were adjudicated by the third observer. The bleb type and among MMC and non-MMC group, overall the bleb types are good diffuse blebs, and with MMC group and non-MMC group, there is not much difference, almost equal in both. Good diffuse blebs are equal in MMC and non-MMC groups. So now coming to the pre-op factors like pre-op IOP and duration of medications, that shows not significantly affecting the bleb morphology. Then coming to the intraoperative factors, what I told previously, none of these are affecting the bleb morphology at 1 year. The factors affecting bleb morphology at 12 months are nothing, none of these factors are affecting, and p-value is insignificant. The IOP profile over 1 year, the most of the patients having IOP around 7 to 18 millimeter of mercury at 1 month, 2 months, 3 months, 6 months and 1 year duration. The overall need of medication, around 80% of the patient at 1 year not required any anti-glaucoma medication in JOAG patients after operating the patient. So absolute success rate as compared with MMC group, it is higher with non-MMC group. That indicates absolute success rate was with IOP control in MMC group is better than non-MMC group. The Kaplan-Meier survival curve, the IOP reduction 30% is better at 1 year as compared to the 50% of IOP reduction at 1 year. The limitations of the study are, large point of the study was retrospective and may have bias associate. The result of this study may are only 12 months, that is 1 year. The difference in the bleb morphology may be more apparent on longer follow-up. The post-operative factors like releasable sutures, timing at what time released, and the bleb massage, use of post-op steroids, presence or absence of bleb leaks, etc. were not evaluated in this study. And patient complaints which may be have reflected on the number of failures, those which qualified with success rate of the surgery. The conclusion is, bleb morphology among JOAG patient undergoing trabeculectomy is varied, though majority have good diffuse blebs. Preoperative and intraoperative factors analyzed in these studies does not seem to affect the bleb morphology. At 1 year, absolute success rate was higher with use of MMC than the not using it. The recommendations of the studies, long-term studies recommended for further assess the factors affecting the bleb morphology, and post-operative factors, as I told you, like releasing suture, timing release, then bleb massage, post-op steroids, like that have to evaluate. Use of low-dose MMC intraoperatively increase the absolute success rate without significantly affecting the bleb morphology. Thank you.
I have a couple of questions.
Yes, ma'am.
So, a large number of patients in your study were in the retrospective
Yes.
arm. How did you analyze the intraoperative factors in these patients? If you go back to your slide, there are a whole lot of like Tennant's thickness.
Yes, yes.
Those you cannot, the OT notes are not going to be mentioning such detailed, things.
Yeah,
So how did
all
you
the
do
details
that?
have been mentioned in the OT notes, ma'am.
Can you just go back to that slide where you talked about it? So why was this done? Did you plan to do a prospective study? I mean, in the OT notes, why were these things mentioned? If you could go back to the slides. I'm quite amazed at the details of the OT notes. The slide where you, can you go back?
Yeah, yeah.
The surgical factors. Yes, this.
Yes, ma'am.
So all this was mentioned in the size of the ostium, size of iridectomy?
Yes, sir, these all cases are done by single surgeon.
Yes.
So they mentioned in all the OT notes.
So is this a normal protocol? Which center was this, if I may
Center,
ask?
ma'am.
So is this a normal protocol to mention
yes,
for
ma'am.
all patients,
Yes,
for
ma'am.
all
For all
surgery patients?
trabeculectomy patients.
Oh, okay. Not that you were thinking that there'll be a part of
No,
study.
no, ma'am.
So in a normal course, you
yes,
mention all these
yes.
details, which is very good.
Yes.
Okay. And did you try to correlate the bleb morphology with, like you said, a few patients required anti-glaucoma drugs even after that?
Yes.
So did you correlate the bleb morphology with how well the patients were controlled? Like which bleb gave a better control, which bleb required anti-glaucoma drugs to be added on?
That
Did
is
you do
not
any kind
evaluated,
of,
ma'am. That will be done for next follow-ups or
Okay.
further.
And then you said that mitomycin worked better, but in one of your previous slides you said
Yes.
that the results were the same. They both gave a diffuse bleb.
Yes, ma'am.
So
That
what is the
morphology,
mechanism? Why would
morphology
you-
among with mitomycin C and without mitomycin C almost
Almost the
good
same.
diffuse. But IOP control in mitomycin use is well controlled.
So what is your hypothesis? I mean, why would you think that this would happen?
So mitomycin might be more effective as not using it.
More?
Not using the
No.
mitomycin.
How would you postulate when the anatomy and morphology of the bleb is similar in both?
Yes.
Why is that group working better? Either we get a different morphology in both the groups, then we
Yes.
can say that one bleb is working better than the other. If morphologically the bleb is the same, then
Same.
why is the mitomycin C group working better?
It is not very much different. Little bit different. That is around.
No, is
Around
it statist-
10%.
Because in the end, that is
Yes,
the major
yes,
outcome.
Yes.
Actually,
That
that
we-
is the major outcome of your
Yes.
study.
Major
That,
yes. Yes.
So how do we apply it into clinical practice? Because at the end of this, we are all very confused. I mean,
Yes.
I'm confused
Yes.
that the blebs were similar in both.
Similar.
So and then the IOP control was better with mitomycin.
Yes.
That is what you're
Yes,
trying to
yes.
say. So I'm asking you, why do you feel this would have happened?
Might
You
be.
would have thought, right? Any imposture?
Yeah, I didn't thought, ma'am.
You didn't think about it. Okay. Can you just go further to your conclusions?
Yes, ma'am.
Statistical data where you show that mitomycin C,
This one.
yeah, okay. So here you are showing that mitomycin C, the IOP control was better.
This red line is this
no
mitomycin
difference
C
in
group.
bleb.
Yeah, 16 18 millimeter of mercury around at 1 year duration. And this black line is no mitomycin group.
Okay.
What was the duration of anti-glaucoma drugs? You said they were on drugs,
1 year.
but these were juvenile patients, right? And
Yes.
they were operated, some of them at the age of 40, you mentioned.
No, age is around.
If you go to your first slide, just go back to your first slide. First one. After this, yeah, just. Can we have this?
Can you maximize it? This is only the characteristic features of the JOAG patients, not for my
Okay.
paper patients are
Affects persons of age group 10 to 40.
40 years.
So, can you just define juvenile for the house for the benefit? Like what?
Juvenile is it is early onset.
What age? Is there a criteria?
This is the mainly only after 10 age of 10 years.
Patients of 35 years,
Yes.
you categorize that person in a juvenile open-angle glaucoma or an adult?
It is patient might be based on these characteristics. Patient might be identified JOAG at 35 also, but it is started at early. That is around 10 years, 12 years, 15 years. So these all the features, that is high IOP, more than 30 millimeter of mercury, deep steep cupping with diffuse visual field defects, open angles on gonioscopy.
So these are the features of even a primary open angle glaucoma. How do you differentiate a juvenile open angle glaucoma from a primary open in an adult? That's what we're asking you.
This is the main age. Age factor is the main. That
So
is why I
what is that
mentioned
age? What is that age?
That before at the starting age is 10 years, ma'am.
Starting age is 10 years in a
years.
juvenile
Yeah,
case.
yeah.
And then here you say affects people of age group 10 to 40.
That is range
It
duration.
can go on.
Yeah.
Okay. All right.
I think if a patient of 30 or 35 years, if you include in your study, so I think that will be the history which will tell you if that the patient was having glaucoma for last 20 years. That is the only way you can make out, right?
History and examination findings we will correlate.
Examination findings पे कैसे पता चलेगा? How would you make a how would you make a difference from?
Yeah.
But
Yeah.
exam.
This is a yes.
This can be in an adult open angle glaucoma as well. Na?
Yeah, that is history also. Patient having
History all
Yes.
That means that is only the history.
Yes.
So for instance, if you get a patient of 38-year-old
Huh,
patient walking, so if you include in your study, if the patient gives you a history ki I have glaucoma for last 25 years,
Huh.
that is the only criteria, right?
That is history.
An examination it would remain the same.
Yes.
And how would you differentiate that adult glaucoma है का patient present कर रहा है?
Huh.
तो उसको तो नहीं differentiate कर सकते.
You can differentiate. Ma'am.
How? That's what is the question
Yeah.
is. That's
See, ma'am, GOG patient differ from adults on onset.
Yes,
POG,
I
the
understand.
disease in the former is more severe consequent to the high IOP at the presentation and severe visual field loss.
Okay. All right. Thank you.